that's an easy answer, I think. I think because there's not much controversy, and I'm not about to throw something out there that not everyone will expect. It's certainly there's a number of things, of course, but the food environment is a big problem, right? It is a big issue. The the access, the type of foods that people are consuming certainly don't appear to be assisting them on their journey for better health. It certainly seems to be doing the exact opposite, promoting overeating, and that combined with a lot of conveniences that modern 21st century has brought about reduces physical activity. And so you have this combination of many people are over consuming, not necessarily to their own fault. Oftentimes subconsciously there's a desire to overeat the foods that are readily available for most people that are often inexpensive, are the ones that people are most apt to consume. And as a result, that certainly seems to put people at a lot of risk for consuming excess calories, not burning many of them, so being more sedentary and less active. And that combination certainly leads many people to become ultimately overweight and then ultimately obese. And when we talk about the growing metabolic health crisis, that seems to be one of the fundamental pillars that is driving many of the issues that we are seeing at unprecedented levels. Not just, of course, where I live in the United States, but across the world. In India, the rates of type 2 diabetes are reaching a peak level, and these numbers don't appear to be slowing down. They seem to be going on an upward trajectory. And so there's certainly a number of reasons that extend beyond that that are a bit more nuanced, but those are clearly key drivers of why people are struggling right now. And the rates of many diseases have gone up, and not all that's obesity related, but a lot of that can be tied back to some of the same problems: the food, the lack of activity, and some other exposures that people may be getting throughout their life that puts them at greater risk. So, yeah, it's complex. It's much more nuanced than what I described, but I think those are the key pillars that are driving a lot of these issues.
And are there any public health efforts which can address these? Do you think anything which is happening now in America, like the Make America Healthy Again movement, any
It,
significance?
that's Yeah, that's very interesting because there's never been at least just from my awareness, a greater level of highlight or a greater spotlight on some of these fundamental lifestyle problems: poor nutrition, lack of activity. That's never, in my opinion, gotten the level of appreciation and exposure that it has recently. And I am hopeful that that will lead to a number of positive changes across the board. There's obviously the emergence of very powerful anti-obesity medications in the context of GLP-1 receptor agonist, and those have been shown basically over and over again over the years, because they used to have oral forms, and then they got them into injectable forms, and that allowed them to be sustained for longer in the body. Essentially, the medications became way more effective due to technological advancement, and that got to a point where it became extremely effective in individuals. And so there's that to consider as well. There is the interest on a political level to potentially address some of these root problems in society that are leading in a lot of incentives for people to develop foods and products that maybe aren't in the best interest or for people's health, and maybe make it difficult for people to sustain health. But then there's also another layer to that where there have been some remarkable technological advancements that really may allow for some individuals who have historically struggled to overcome some of these key challenges, to have a tool finally in their toolbox to address at least one of the root causes of some of these metabolic health crises, which is a problem with overconsumption, or the problem of being hungry or consuming even when maybe someone doesn't have the perception of hunger, just for the seeking of a positive response. And so that emergence and the emergence of the drugs are only getting way more powerful is another layer to this. In fact, there's some public interest in some key individuals on a political level who've been talking about this, and certainly not going to be one or the other. It's These are all in consideration or on the table for addressing these issues. So the only thing that has actionably happened, to be totally frank, is the emergence of these medicines, because we have been talking about change. We know that food works. Most people know that changing your diet works. The problem with changing your diet is that people don't know necessarily how to do that or where to get information to do it effectively. That's a major difficulty and problem, because you can go anywhere on the internet and look for resources and find a lot of misinformation. And that may lead you to fail on the approach and then ultimately feel discouraged and then just repeat the cycle. So that's obviously not helpful. When someone's looking to engage in physical activity, a lot of times they're looking at these elite level athletes and saying, okay, well, if I want to be great, I have to do what they're doing. And that's also terrible approach to do. Everyone wants to be like like in America in basketball. If you want to be a basketball player, you look at LeBron James. If you want to be a sprinter, you might look at someone like Usain Bolt or some of the emergent sprinters. And but that's a bad approach. These people never started being that great. They worked at a different level. They started by taking a step, then they took steps, then they started started to jog and then run and then sprint. They never started there. At least most people don't. And so for most people, it's just about starting and taking the first step in physical activity. And then, all these things combined, there's a whole list of helpful tools out there for people to improve their health, but most people are having difficulty engaging with them or finding effective approaches on how to do it. And these have created a lot of barriers. So I think in general, I'm hopeful that the next few years will lead to a revolution in metabolic health, but you never can guarantee it.
Absolutely.
Right. So speaking of revolution, the emergence of the international therapeutic carbohydrate reduction has been nothing short of a milestone. So, why do you think even like it's been delayed so far, like so long? Like, why do you think there's so much resistance against acceptance of carbohydrate restriction?
Yeah, so carbohydrate restriction, for your audience, for them to know, it is very controversial. It has been very controversial for a number of years, but it's important for people to understand that this has actually been around for hundreds of years. It was actually standard of care before the discovery and Nobel Prize of insulin, and so that should ease some people's apprehension, because it's not new. This has been around for frankly centuries to treat obesity, type 2 diabetes, and type 1 diabetes. The lack of guidelines is quite an interesting story, because the first emergent nutritional guidelines for people with diabetes in general was in the 1960s from the American Diabetes Association. And the American Diabetes Association made the statement at this time that people with diabetes should eat the same food as those without diabetes. And so about 10 years later, they kind of doubled down on this philosophy. But keep in mind that kind of stuck for a few decades. And that was despite never having evidence to support that claim. It was more of an assumption that those with insulin now available, they should be able to eat the same foods as those who don't have the disease. And I believe that was a misstep. I think that was an error in assumption. And as a result, it caused a set precedence in what is and isn't healthy, not based on evidence, but based on assumption. And as a result, that led to many people believing that doing the opposite of what was set in stone based on these assumptions was maybe not the healthy approach, or something that you should do, because it's different, it's restrictive. And then there was also this convoluted precedent set, because it was used for seizures or people with neurodegenerative disorders, or for seizures for 100 years. But the way it was being implemented was initially extremely restrictive. So over 90% of the calories from fat. And that's a very difficult and often unsustainable way of doing the diet. And the vast majority of people who say I'm doing a ketogenic diet are never doing this traditional ketogenic diet, which is a 4-to-1 ratio, or 90% of the calories from fat. I mean, that's mostly a liquid fat form of the diet. People don't appreciate that's not what they're often doing, but that was what was done in the medical literature for seizures even at Johns Hopkins, not too much further back than like 20, 30 years ago. And so when kids were looked at for these diets, there was often there was a large number of kids with refractory epilepsy who were able to see remarkable improvements. Not everyone improved, nor would you expect that in any intervention, but many did. But there was also reports that some of these children also had maybe issues of growth. The issue with that is that that was an extreme form of the diet that most people would not implement or sustain, with low protein levels, altered calorie intake, a whole bunch of reasons why that would not be representative of the traditional approach. And so this led to assumptions that, okay, well, what's happening in that extreme form of the diet is going to happen over here in a more well-formulated, higher protein, more balanced approach. And there's all these hypothetical risks that started to be proposed by many people in the medical establishment, which was, hey, you know, one of the biggest issues more than anything, especially in type 1 diabetes, for gaining some level of appreciation for this approach, is that ketone bodies, if anyone has heard of this before, that really got a bad rap from the disease I have, which is type 1 diabetes. Because that is what was elevated at extremely high levels. That was the one thing to distinguish someone for having the onset of type 1 diabetes, and they end up in the hospital, and some people often died because these ketone levels were getting so high. And lack of awareness, people said, okay, what must be the ketones that are causing these patients to get sick and some die? And it was never the ketone bodies that were the problem. In fact, the last 10 to 20 years of evidence has shown that these are remarkable therapeutic metabolites with a lot of health potential. It was the acid load that was a byproduct of ketone metabolism when insulin is completely absent, which is almost never the case in any other physiological environment. That acid load becomes so high so quickly, the body can't adapt quick enough to it. And as a result, it causes acidosis, something called diabetic ketoacidosis. So just at first glance, people think, okay, well, if you're going to do a diet, that I've heard of this diet called a ketogenic diet. Doesn't it elevate ketone bodies? And aren't ketone bodies what hurt patients with type 1 diabetes? Well, no and no. But that's the assumption people were going to, historically speaking. And actually, that's still, unfortunately, around. But there's a number of other reasons that people are apprehensive about this approach. But a lot of that is based in hypothetical and unsubstantiated risk, often due to misinformation. And so the reason we, in a group of other individuals, specifically Beth McNally, Amy Rush, Francisca, Caroline Roberts, a team of international experts and people often living with type 1 diabetes or treating patients with type 1 diabetes, with over 10 reviewers from around the world, came together to build guidelines because there were none. What was happening is that there were signs of evidence of this remarkable therapeutic potential of lowering carbohydrates in diabetes. Specifically, what I'm talking about here is type 1 diabetes. But we also know for years or over a century that people for type 2 have used this approach. But there were never any guidelines for type 1. And there were many healthcare practitioners that were seeing patients come into their office and just starting and doing this approach. And they would often reach out to me. Maybe they found me on a Google search or something along those lines, and would say, I don't know what to do here. How do I help this patient? And this is from some of the best diabetes institutes in the entire world experts in treating diabetes. But the problem here is that if you're a medical professional who is treating a patient, you often have to do so under the guise of something called standard of care. And these are based on guidelines set from major institutional bodies that allow for clinicians to follow a set criteria by which they can care for patients. If they step outside of that path, they run the risk of, if something doesn't go right, that someone could come after them in their medical license. And so the problem is that no one had ever wrote guidelines for type 1 diabetes in low carbohydrate nutrition. No major institute had. They had written guidelines for type 2 diabetes in adults, but never for type 1 diabetes across all age groups. And so many healthcare practitioners felt unsupported. In fact, there's evidence from Annalyn Conklin's group, who's a a well-known epidemiologist at University of British Columbia, surveyed clinics and found that many healthcare practitioners, specifically people who were experts in diet, dietitians and nutritionists, either one, didn't feel supported by their healthcare team to implement carbohydrate restriction, or two, they themselves felt uneducated on how to do the approach. And over 66% of those dietitians and nutritionists who were surveyed reported this. So 2/3 felt unsupported or unprepared to do this approach. Well, why would that be? Why would it, one, be unsupported, or two, they felt they didn't have enough resources to do it correctly? Well, almost certainly the rationale for that is because there were no guidelines. There was nothing out there that says you can do it and do it safely this way. And so I reached out to many of the major institutes and said, hey, look, you guys have a problem here. People are doing this approach without any healthcare support. In fact, the evidence also supports that most patients do this with minimal or no healthcare support in type 1 diabetes. I'm hearing from endocrinologists and dietitians and nutritionalists and certified diabetes educators, et cetera, all over the world at some of the best institutions that they're asking me, what do I do? This is a huge problem. Hey, look, you guys don't have it in your guidelines how to address this, and you need to. Well, that was over a half a decade ago. And so we kept asking, kept pushing, kept saying, hey, we'll help with this. And essentially just got to the point where the community themselves, the people who were supporting people with this disease, the people who were living this disease, decided that we were going to do it ourselves. And we decided to build international institutional guidelines for the first time ever from people who not only lived with this disease, treated this disease, researched this disease from many levels of the healthcare rung, whether it be a physician, endocrinologist, primary care, to a dietitian, nutritionist, or certified diabetes educator or researcher. And we brought those individuals together, and it was ultimately put out by the Institute for Personalized Therapeutic Nutrition, which is an international-based organization that supports individuals implementing safe approaches for nutrition to treat disease. And so it gives people the opportunity to look for and actually find resources to help them guide their patients on the journey, because as these people want to help their patients, but in the absence of resources, in the absence of guidelines on how to do that, they could be at risk. And so I like to say that this was guidelines that were built by the community for the community. And that was really the goal, to address a major gap. And I'm hopeful that it translates to helping many patients along their way.